Welcome to the Guide Me MD podcast, the audio first platform designed to bridge the gap between textbook pathology and real world ward survival. My name is Lina.
And my name is Alina, and we are the founders of the Guide Me MD Foundation and your hosts for our second episode of the Guide Me MD podcast.
Before we start and step onto the ward, our standard medical disclaimer. This podcast is strictly for educational purposes and does not constitute a medical advice or a clinical consultation.
Every case we discuss is 100% simulated and fictionalized with no real patient data. If you have a real medical concern, please contact your doctor or head to the nearest emergency center immediately.
We know the ward can feel like a storm, but you don't have to navigate it alone. Trust the compass. Your ward survival starts right here.
Let's get right to it. The team is waiting at the nursing station for segment 1, the handover. You are the intern on call for the emergency department, and you've just been handed the chart for bed 7, a 45-year-old female presenting with severe abdominal pain.
The triage nurse reports her vitals. Our patient is tachycardic at 110 beats per minute, slightly febrile at 37.8 degrees Celsius, but her blood pressure is stable. The clock is ticking, and we need to lock down a structured history to rule out surgical red flags before the attending round.
Take a breath, grab your pen, and let's step behind the curtain. Welcome to segment 2, the role play.
Good evening. My name is Dr. Guide, and I'm one of the doctors working in the emergency department tonight. Before I examine your tummy, would it be all right if I asked you some questions to understand exactly what's going on?
Yeah, please, doctor. It just hurts a lot.
I can see you're in a lot of pain. I'm so sorry to hear that. I do want to get you some relief as quickly as possible to make sure we give you the right medications. I just need to ask you a few questions first. Can I confirm your full name and age, please?
It's Alina Doe. I'm 45.
Thank you, Alina. Can you tell me a little bit more about the pain? When did it exactly start?
Well, I'd say it started like 12 hours ago. It was right after dinner last night, and it just hasn't gone away.
Can you point with one finger to exactly where it hurts the most?
It's like right here in the middle and upper part of my tummy, just under my ribs.
What kind of pain is it? Is it sharp? Is it burning? Cramping?
It's a really deep, dull, aching pain.
Okay. And does the pain stay right there under your ribs, or does it move or shoot anywhere else?
Yeah, actually, I'd say it wraps around my back. And weirdly, I feel like my shoulder, my right shoulder is aching too.
That's very helpful detail. Thank you, Alina. Since it started 12 hours ago, has it been getting better, you would say, or worse, or is it exactly the same level of pain?
No, it's definitely getting worse.
Okay, and you mentioned that it started right after dinner. Do you remember exactly what you had to eat?
Well, we actually had guests over last night, so I made a big batch of macaroni and cheese with meatballs, and it was a pretty heavy meal, I'd say.
Okay, and on a scale of 1 to 10, with 10 being the absolute worst pain that you've ever felt, where would you rate it right now?
It's easily a 9 out of 10.
No, okay. And have you found anything that makes the pain slightly better? Or maybe worse?
Well, I tried using a warm water bottle, but that didn't do anything. Leaning forward seems to help a teensy bit, but if I move around too much or if I try to even lie flat on my back, it gets unbearable.
Okay. And Alina, have you had the pain like this before, or is this the first time you've ever experienced something like this?
Actually, yes. I used to get a similar dull, achy pain in the exact same spot on my tummy, but it was never this painful. And before, it would only last maybe an hour or two and it would go away on its own.
Did you notice if those shorter episodes that you experienced before also happened after eating anything specific?
Usually it was after really heavy or greasy meals.
Okay, and that's really important to share. And along with this pain, have you felt sick or maybe nauseous?
Yeah, I threw up 3 times after dinner last night. The first time that I threw up, it was just my food, which was expected. But after that, it was this really awful, painful yellow liquid.
Hey, that's really unpleasant. I'm so sorry, Alina. And did you notice
Mhm.
any blood or anything that looked like dark coffee grounds in the vomit?
No, definitely no blood. That sounds awful.
Okay. And if you were to quantify the amount that you vomited, how much would you say amount?
I wouldn't be able to tell you, doctor. It was definitely a lot.
Okay. And have you noticed any changes in your bowel movements? Perhaps any diarrhea or constipation?
No, my bowel movements have been normal.
Okay. And how about your urine? Has it become unusually dark or maybe the color of tea or cola?
No, it looks normal.
Have you felt hot or had any chills at home before coming in?
I felt a little warm, but I didn't check my temperature.
Hmm. And have you noticed the whites of your eyes or your skin turning yellow or someone telling you appear a little yellowish in tone?
No, nothing like that.
Hey, that's good to hear. And have you been experiencing any chest pain or feeling like your heart is racing?
No, not at all.
Okay, that's good to hear. And just to completely be thorough, as we do with any female patient coming in with abdominal pain, is there any chance that you could be pregnant?
No, definitely not pregnant, doctor.
And just to ask you a few more questions, is your menstrual cycle regular?
Yes, it's always been regular.
Do you experience any irregular bleeding in between or pain outside of your cycle?
No, no, nothing like that.
Okay, I'm glad to hear that. Thank you, Lina, for answering these questions. Before coming to the emergency department, did you try taking any medications at home for the pain, like ibuprofen or paracetamol?
I didn't take any painkillers. I usually take some over-the-counter antacids when I get a heartburn after a big fatty dinner like the one I had last night. So I was thinking maybe it could be heartburn related. I took some antacids last night, but they didn't help with this pain at all.
Okay, we'll definitely run a few tests, but first, would it be okay if I ask you some questions related to your past medical history?
Yeah, that's fine.
Since you mentioned taking antacids for heartburn, could you tell me a bit about that? How often do you usually get these heartburns?
Usually after I eat a big dinner, like the one last night, maybe a couple times a week if I had to guess.
And how long has this been going on for?
Mm, Probably for a few years now.
And do you know the exact name or brand of the antacids that you take?
No, I honestly don't know the name. I just grab whatever's on the shelf at the pharmacy. It usually helps me to sleep though.
Okay, we can look into that later. Let's talk a little bit about your general health now. Aside from the heartburn, do you have any other long-term medical conditions we should know about?
No, I don't have anything. My doctor just tells me I need to lose some weight.
Okay. And you don't have any high blood pressure, diabetes, or high cholesterol?
No, nothing like that.
Okay, I'm glad to hear that. And have you ever been admitted to the hospital overnight for any reason in the past?
No, I've never been hospitalized.
That's good. And what about surgeries? Have you ever had any operations done, like maybe appendix removed or gallbladder?
No, I've never had any surgeries.
Are you taking any other regular medication aside from the antacids?
No, just those antacids occasionally.
And any daily pills or inhalers or supplements?
Nothing.
And finally, do you have any allergies to any medications?
No, not that I know of.
And any severe allergies to latex or specific foods?
No, no.
Okay, great. Now let's move on to your family medical history, if that's okay with you, Lina. Are your parents both alive and well?
Well, my mother is still alive, but unfortunately, my father passed away.
I'm so sorry to hear that about your father. And if you don't mind me asking, Alina, when did he pass away? And do you know why?
He passed away from a stroke when he was 65, and thank you, doctor.
Okay, I'm so sorry, Alina, again. That must be really hard. Thank you for sharing that. And how about your mother? Does she have any long-term health conditions we should be aware of?
She's mostly healthy. She occasionally gets gallstones. I don't know what that is, but she's mostly healthy.
Okay, just to be thorough, are there any other medical conditions that run in your extended family?
No, not that I can think of.
Any heart disease, diabetes, or any history of stomach, colon, or pancreatic cancers?
No, no, nothing like that. Just the stroke with my dad and the gallstones with my mom.
All right. Thank you so much, Alina. And now I'll shift gears and ask you a few questions about your lifestyle and home situation. Would that be okay?
Yeah, that's fine.
Who do you live with at home?
Well, I'm married, so I live with my husband, and we have 3 kids. We all live together.
That's lovely. And do you work?
Yes, I do actually. I'm a school teacher.
Oh, that sounds exciting. A very busy household and a busy job. Between work and home, are you able to find any time to exercise?
Honestly, no, I just can't find the time between the kids at school and my own kids at home.
Completely understand. Because of this abdominal pain, I'd like to get an idea of your daily diet as well. What kind of daily meals do you typically eat? I know you mentioned a few fatty foods, but what's your regular diet like?
I mostly just cook what the kids like best. So lots of comfort foods like mac and cheese. My kids love mac and cheese. Or maybe spaghetti and meatballs.
Okay, thank you for sharing that, Alina. Now I just need to ask you a few standard lifestyle questions that we ask all our patients. Would that be okay with you?
Yeah, that's fine.
Do you smoke by any chance?
No, never.
And how about alcohol? Do you drink?
I usually have 1 or 2 glasses of wine with dinner on most nights. But actually, now that I remember, I think I was drinking a little more about 2 nights ago when we had those guests over, actually, that same dinner party. If I had to guess, I think I had maybe 5 or 6 glasses.
Okay, thank you for being open about that, Alina. And do you take any recreational drugs?
Oh, no, not at all.
Okay, thank you, Alina. I'm just going to ask a few rapid fire questions to make sure we haven't missed anything. I'll ask these fairly quickly, so just say yes or no if you have these, okay?
Okay.
Have you had any severe headaches, dizziness, or sudden changes in your vision?
No,
And any new cough or wheezing or shortness of breath?
no,
And you mentioned your urine was normal in color. Have you had any pain or burning when you urinate? And no changes of how frequently you go to the washroom?
no,
And any unusual vaginal bleeding or discharge?
no,
Okay. And have you noticed any new skin rashes or any sudden swelling in your legs?
no,
Any sudden swelling in your joint?
no,
And have you experienced any sudden numbness, tingling, or weakness in your arms and legs?
no. No other complaints. Everything else feels completely fine. It's just this awful stomach pain and the vomiting.
Thank you, Alina. You've been incredibly helpful in answering all these questions. We're definitely going to look into this pain and examine your abdomen. But before we do, I always ask my patients a few questions to understand their perspective. With everything you've experienced since last night, what do you think might be causing the pain?
Well, since you asked about my family earlier, I'm thinking maybe I have gallstones, the same thing my mother has.
That's a very reasonable thought, Alina. We'll definitely look into that more and conduct a few investigations. Is there anything else specific that you're particularly concerned or worried about right now?
Honestly, my biggest concern is, of course, this pain and its severity. And it's just also standing in the way of me doing my job properly and tending to my kids. I have a really busy life, and I just can't afford to be out of commission.
I can completely understand how stressful that must be, especially with three children at home and working as a teacher as well. Is there anything else I can help out with? Do you have any other expectations from our team today?
I just really want you to get this pain under control and help get me back on my feet as soon as possible.
And that's exactly what we're going to aim for as well. We're on the same team, Alina. My immediate plan is now to get you an IV line started so we can give you some strong pain relief and some fluids for dehydration from the vomiting. Then I'm going to examine your stomach, draw some blood work, and order an ultrasound for your gallbladder, okay? So we can take a direct look on your stomach. I'm also going to step out just for a bit to write these orders down, and the nurse will be right here to help you, okay?
Okay, thank you so much, Dr. Guide. I feel a lot better already just by knowing the plan. And scene. Dr. Guide has stepped out to place the orders for analgesia and the abdominal ultrasound. All right, Lina, let's step out of the emergency cubicle and into the OSCE grading room for segment 3, the discussion and debrief. I'll be your and scene. Dr. Guide has stepped out to place the orders for analgesia and the abdominal ultrasound. All right, Lina, let's step out of the emergency cubicle and into the OSCE grading room for segment 3, the discussion and debrief. I'll be your examiner for this station. Now, that was an excellent history. My first question is, what is your primary list of differential diagnoses, and what are the specific risk factors that this patient exhibits?
Thank you so much, Alina. My top differential is acute cholecystitis. This patient fits the clinical profile perfectly, especially if you use the classic F risk factors mnemonic, where she is a female, she's in her 40s, since she's 45, she's fertile, as she has three kids, she's fair, and has a strong family history where her mother also had gallstones. And she also mentioned that her doctor advised her to lose weight, covering the fat or obesity risk factor as well. So she checks the boxes for all of those.
Excellent identification of those risk factors. Now, what else is on your differential list, and how exactly are you going to rule them out?
Okay, so there are a few other differentials on my list. I would need to rule out biliary pancreatitis and cholelithiasis. I can never say that word, which is why I asked about the dark urine and the jaundice, as well as changes in stool, namely looking for pale stools. I'm also considering peptic ulcer disease given her history of postprandial heartburn and antacid use. I would also add acute hepatitis on the list, but lower. Most importantly, I would want to rule out posterior myocardial infarction, which is why I specifically screen for chest pain and palpitations.
Great work, Lina. That was a very comprehensive list of differentials. Now, before the examiner is going to let you order these investigations, you first need to examine the patient. Talk me through how you're going to go about a physical examination in this patient specifically.
I would definitely go for abdominal examination to assess our patient, going through general inspection, then closer inspection. I would also examine in the face for any signs of dehydration, cyanosis, jaundice, and or anemia. And I would also check for exophthalmos if we're considering a thyroid issue in our differential. And then from there, I would move on to the abdomen, conducting a closer inspection and palpation of the abdomen. I would be checking for localized tenderness, involuntary guarding, or rigidity, specifically in the right upper quadrant where the patient said that they were feeling the pain. But the hallmark that I'm trying to find is eliciting a positive Murphy sign.
Okay, since you mentioned Murphy sign, could you explain to me how you would check for it on the warts?
I would ask the patient to exhale completely. Then I would place my fingers firmly just below her right costal margin, right at the mid-clavicular line where the gallbladder sits. Finally, I'd ask her to take a deep, slow breath in. As her diaphragm moves down during the inspiration, it pushes the inflamed gallbladder directly into my fingertips. If she suddenly catches her breath or stops inhaling midway due to the sharp pain, that's a positive Murphy sign.
Great work, Lina. You explained Murphy's sign perfectly. Full marks for the physical exam. Now, walk me through your investigations.
I would divide up my investigations into bedside, labs, and imaging. For bedside, I would be taking her vitals and then moving on to lab workup. I would order a complete blood count and a CRP to check for any underlying infection or anemia. I would also order a urea electrolytes or renal function test to assess for her kidney function, her hydration status since she was vomiting, as well as for a baseline before any contrast imaging. I would also want to order liver function tests. Critically need these to check for any obstructive patterns indicating cholelithiasis or a hepatocellular injury pointing towards hepatitis. I would order an amylase and lipase as I'm looking for a level more than the 3 times the upper normal limit to confirm acute pancreatitis. I'll also order coagulation profile for any pre-procedural planning as well as blood cultures as just a part of a complete sepsis workout.
Perfect. Amazing work, Lina. And what imaging are you going to be requesting?
Following the principles of using the simple investigations first, I would begin with a plain X-ray and an ECG to rule out atypical cardiac causes of upper abdominal pain, and then following that, an abdominal ultrasound. I would go for the least invasive first. I'm looking for a thickened gallbladder wall, the presence of gallstones, or a dilated common bile duct. If I suspect acute cholecystitis complications or pancreatitis, I would step up to order a CT abdomen. If there is a suspected cholangitis or stones lodged in the biliary tree, I would order a magnetic resonance cholangiopancreatography, short for MRCP. That would be my mode for imaging for confirmation.
Okay, let's say the ultrasound confirms acute cholecystitis. Now the patient's heart rate is climbing and she looks unwell. How would you manage this patient in an emergency setting?
I would immediately initiate an ABCDE approach and secure a large bore IV access. If she's septic and her oxygen saturation drops below 94%, I will provide supplementary oxygen. I would start aggressive IV fluid resuscitation with Ringer's lactate, and at the same time, I will administer IV broad spectrum antibiotics.
Great job, Lina. You did amazing work on this case. Let me ask you a bonus OSCE question. What would be the specific role of metronidazole if this case was complicated by an intra-abdominal infection?
Metronidazole specifically provides anaerobic bacterial coverage, which is absolutely essential for a gut and biliary tract infection.
Spot on, Lina. Now, let's say the patient is stabilized. What is the definitive treatment plan?
The gold standard definitive treatment is an early laparoscopic cholecystectomy. If she is unfit for surgery or too unstable, we would opt for gallbladder drainage procedures such as percutaneous cholecystostomy or endoscopic gallbladder stenting.
Great overview. Final question to close out the station. If this patient had any sort of delay coming in, what complications of acute cholecystitis would you be worried about?
I would be highly concerned about gallbladder perforation, gallbladder empyema, or even progression to gangrenous cholecystitis. Some other major local complications can include pyogenic liver abscess, fistulas, or pericholecystic abscesses even. There's also long-term complications that can occur if the patient goes on untreated, which can lead to chronic cholecystitis.
Great overview of the complications, Lina. Now let's change up the scenario for a second. What if the same patient with right upper quadrant pain also had a high spiking fever, shivering, and was deeply jaundiced? What would your diagnosis be now?
The combination of right upper quadrant pain, fever, and jaundice is known as Charcot's triad, and that points to ascending cholangitis.
Perfect. Now, let's say her blood pressure began to crash, and all of a sudden she became severely confused.
If you add hypotension and altered mental status to the Charcot's triad, that makes it Raynaud's pentad. That indicates a patient has gone into septic shock, which requires an emergency biliary decompression, usually an ERCP, rather than a standard laparoscopic cholecystectomy.
Amazing work. You immediately recognize the surgical emergency. One last tiny anatomy question. Okay. During the patient's history taking, she mentioned the pain was radiating to her right shoulder. What is the name for that referred pain, and why is it happening?
That's known as Boas sign. It's caused by irritation of the phrenic nerve due to the inflamed gallbladder, irritating the diaphragm, which refers the pain up to the right shoulder or beneath the right scapula.
Amazing work, Lina. You've thoroughly gathered the history, navigated the clinical traps, and perfectly outlined the management plan. You've definitely passed this OSCE station. And that wraps up our clinical debrief for today's case, acute cholecystitis. If you found yourself mentally reciting those 5 F's alongside us, you're building the exact muscle memory you need for the wards.
To help you lock in today's surgical frameworks, we have uploaded the full checklist of acute abdomen directly onto our Discord hub.
Whether you're an IMG preparing for your board exams or a brand new intern trying to survive your first surgical night shift, the Discord hub is our newly launched medical resource center. Click the link in the show notes to join the global union.
If you found today's clinical compass helpful, please leave us a thumbs up and share this episode with your co-residents and medical friends. It helps us keep the foundation growing and free for trainees everywhere.
Until next time, keep studying the frameworks, watch out for those red flags, and always remember, trust the compass.
See you on the wards, doctors!